Welcome everyone to our MStranslate Q&A tonight. It's our pleasure to be joined by Dr. Tomas Kalincik from the Melbourne Brain Centre at the Royal Melbourne Hospital and the University of Melbourne. As you may have seen last week, we featured a video with Dr. Kalincik talking about some of the recent research that has been published based on the work that they're conducting through the MSBase group. Thomas, thankfully, I'm very pleased to say, accepted our invitation to participate in a Q&A with members of our community tonight. So maybe, Thomas, if we could just start, just for people who may not have seen that video, can you just give us a little introduction to that research that's been published?
Thank you, Brett. Thank you for this opportunity to actually talk about the result of our research to people who are interested in it. That particular piece of research that we featured last week looked at disability outcomes in people with moderately advanced / advanced multiple sclerosis. This is defined by EDSS steps, or which we tend to take as milestones. We looked at progression, the rate of progression of disability between EDSS step 3 and 6, or 4 and 6, and even later between step 6 and 6.5. So these are, broadly speaking, milestones that are defined by significant limitation in terms of walking capacity. EDSS step 4 means the inability to walk more than 500 meters unassisted or without aid. EDSS step 6 means inability to walk more than 100 meters, or ability to walk approximately 100 meters with help of a cane. And EDSS step 6.5 means requirement of bilateral assistance to walk at least 20 meters. So these milestones, as you can see, are quite solid milestones. It's something that is very difficult to confuse for something else, so that's why we tend to use them. And what we wanted to look at is a hypothesis from a French group of Charles Sedan and Emmanuel Larrey from 2010, where they have shown in their publication in Brain that irrespective of how quickly a patient advances from EDSS step 0, which is normal neurological function, to EDSS step 6, after that step, everyone will progress at the same rate. While they haven't specifically interpreted their data this way in their paper, many of their readers, and actually quite a few professionals and even policymakers have interpreted it this way, which has resulted in some jurisdictions in somewhat nihilistic policy of discontinuing therapy or limiting access to therapy for patients who have reached EDSS step 3 or 4. And a good example of this is Pharmac in New Zealand, where people lose access to DMTs after EDSS step 4. So we have shown that this is indeed not true, and I have, in our brief sketch that we recorded last week, explained what were the errors in the interpretation of the results. We have shown that indeed it does matter that people remain on therapy, particularly the highly effective therapy, even after this significant milestones, and that people who remain on highly effective therapy for a greater proportion of time are less likely to progress or progress at a slower rate than those who are untreated.
Okay, fantastic. So I'm sure that there's a lot of questions that people have got, so I'll throw it open now to the audience. Whoever wants to go first.
Perhaps I could just ask the question, Thomas. In the presentation we did last week, you talked about information. It was one of the first concepts you raised. And when you're doing that, what did you use to measure inflammation? Was it just this EDSS score, or was it more broad than that?
Inflammation is one of the important pathophysiological components of multiple sclerosis, and to be able to measure it in a living human, our resources are very limited. So what we use are pieces of evidence and of research, quite extensive research from animal models of multiple sclerosis. However, these are only models and they are not identical to multiple sclerosis. I'm speaking about a model specifically called EAE, where we are able to take brains of the animals with this type of a disease and look at the brains under the microscope. In human situations, there are blood banks of brains from donors with multiple sclerosis who have agreed after their death for the brains to be stored and used for research purposes. So we have some information from this material about what is happening inside the human brain when one gets diagnosed with multiple sclerosis. However, for us to look from the outside at the inflammation, we use proxies, and the proxies are mainly clinical. Our proxies are, the most obvious proxy is a relapse. So a presentation of new symptoms or worsening of previously existing symptoms and recording the incidence of these relapses in time, also location of the relapses, which tells us about whereabouts in the brain or spinal cord new inflammation is likely to have occurred. And the second piece of evidence comes from imaging, particularly brain MRI, which is a routinely clinically accessible instrument where we can visualize the occurrence of new lesions. They extend their volume, they change compared to the previous MRI. And newly, there are new research tools such as specific markers you can use with PET, positron emission tomography, which is the cutting edge of the research, but that's really early days in something that's not accessible in routine clinical practice. And these techniques help us measure occurrence of a specific cell types, inflammatory cell types in a human brain in vivo. But this is the sound of the future, and at the moment it's strictly reserved to research. Does that answer your question, Andrew?
Yes, I suppose it does. What I was trying to get at is you're doing this measure of how well people can walk to get your base score from which things would change. And then you mentioned information. I was trying to work out how you were actually going to correlate the two things together, because they can have different paths.
Okay, so actually my answer was a relevant sort of prelude to the second part of the answer. So what we specifically look at, we used one of the proxies. So we used the incidence of clinical relapses, which tell us about clinically demonstrable new bout of inflammation in these patients' nervous systems, and we have mapped the association in that frequency of relapses and the rate of progression in terms of the disability, which is what we rate with the EDSS score. So EDSS score doesn't look at the acute inflammation, but it specifically looks at the accumulation of disability, which can be secondary to the acute inflammation, but also can happen independent of that inflammation. And why the later stages of the disease, or moderately advanced to advanced stages of the disease, become problematic in that sense is that we're looking at a combination of two different processes happening at the same time. One is accumulation of disability due to relapses or due to acute inflammation, and the other one is slowly progressive accumulation of disability, which is unrelated to the current relapse activity. So we have used immunomodulatory therapy, so therapy that modulates the activity of immune system to see, or we haven't used it, we have looked how this therapy, when used in routine clinical practice, could have influenced this progression of disability in moderately advanced or advanced disease. And what we saw is that the people who benefited the most from this therapy were those who were still having relapses. So, in other words, if someone with advanced disease is progressing without experiencing relapses, we can't. It's more difficult to assume that these people would benefit from highly effective therapies versus those who are still experiencing relapses.
So the follow-on to that is, did the different therapies, do they have different efficacy? If so, so not all of them are going to be doing exactly the same thing, I presume. So did interferons work better than polymers, or what worked best?
So what we know is from a number of head-to-head studies that we have done, but also from head-to-head trials, where comparative trials of therapies, there seem to be several categories of therapies which can be stratified in such a way according to their perceived or observed effectiveness. We tend to view the interferons and glutamate acetate, which we also call as a group injectable platform therapies, as the least effective of the available immunomodulatory therapies. The middle class being oral therapies such as fingolimod or dimethyl fumarate, excuse me, and the most effective therapies in general tend to be monoclonal antibodies such as natalizumab, alemtuzumab, rituximab, and now newly also ocrelizumab.
So I think just to pass it on to someone else, we did have a question that sort of follows on a little bit from that submitted online. That the person who submitted is here. Bozo forgot, I'm going to use your screen name.
Boyan's fine.
Did you want to ask the question that you sort of submitted to us in advance of this?
I'm trying to remember what it was. I do have another question, if that helps.
Ask your other one. I've got yours written. I've got the other one written down if you do want me.
So I'll do one, and if you don't mind reminding me of the last question.
Yeah, go for it.
Just wondering how all your work, Dr. Kalincik, I hope I'm saying it right, how it's associated with the principle that before you diagnose progressive MS, you need to see a year of progression. If everyone doesn't progress at the same rate, is it not reasonable that some progressive people will progress in a year and others won't?
So that specific definition is a diagnostic criterion. It is a somewhat arbitrary definition, and we have to create these arbitrary definitions if we want to be able to compare in a reproducible and unified manner patients with a progressive outcomes in people with a progressive disease. However, that doesn't mean that people only become progressive after 1 year of progression. Is that what you mean? That
no,
people have to be progressing for at least a year before they become secondary progressive? Is that what you mean?
Yeah, so if somebody does progress in an arbitrary 12-month period, does that necessarily mean it's progressive MS, and the other way around as well? If they don't, does it mean it's not progressive MS?
I see. It doesn't. And we have looked into this in more detail last year using the MSBase cohort, which is a cohort that consists of 41,000 people around the globe. So what we have found that the best fitting definition, or the definition that best describes the clinical reality, is a definition of the minimum EDSS score of 4, so limitation in the capacity to walk 500 meters without assistance. The definition of the minimum step progression in terms of EDSS, but also there are additional definitions such as there has to be impairment in motor performance, and the progression that we observe has to occur without being attributed to a relapse. And in that situation, we only require confirmation of that progression over 6 months. I know this is a complex definition, but this is a definition that we propose for the purpose of trials and clinical studies. So it's something that we can clearly reproduce without necessarily relying on our personal impression whether this is or this is not secondary progressive disease. So to your question, so this is a trial level or study level definition of secondary progressive disease. Probably what you are more interested in, and correct me if I'm wrong, is a more real life type of a definition, which is something that we can only arrive at in retrospect by definition. because at the time that a person first time progresses without a relapse, we can't say if this is simply a once-off event or anecdotal, or there was a bout of inflammation that didn't necessarily present itself as a relapse. But when we look at the brain MRI, and all of a sudden we see a couple of new lesions to which this progression can be attributed. But what typically a clinician would do is to look at consistent, sustained progression of disability over 1, 2, 3, 5 years, and then retrospectively attribute the onset of that progressive phase to, say, sometime around 5 years ago. So unfortunately, we are not very good at the individual patient level at indicating in real time the onset of the progressive stage. However, given that we don't have a therapy that is specific to secondary progressive disease and would be different to relapse and remitting stage of the disease, from the management point of view, that doesn't mean a major difference.
But the 12-month period is fairly arbitrary. It doesn't really have meaning.
It's fairly arbitrary. It's mostly for the purpose of clinical trials.
Thanks.
So I'll follow that up with the question that was submitted online, and I'll just sort of narrow it down to the sort of key points. So it was based on some data that had come out of the UK recently, suggesting that about 50% of patients treated with Lemtrada required 3 or more doses, whereas the ones in the study that you guys have published recently said that only about 10 to 15% had 3 or more doses of Lemtrada. Does this mean that the Lemtrada cohort used in the study was underdosed? And would that have any sort of impact on the results?
Yes, I see. This is a very good question, very relevant question, and I like that the person asking this question is really scrutinizing the data and will be presenting. It's always good to have, important to have this healthy level of skepticism. So the first thing I noticed, first thing I want to clarify is that the Lemtrada data that we used in that particular study, so this is a different study, we're not talking about the study that we did the brief intro on. This is a study that we presented recently at lectures comparing Lemtrada to 3 other highly effective disease-modifying therapies. So the Lemtrada cohort that we used is a real-life cohort. It is not a trial cohort, and it is a real-life cohort that is from 7 UK centres where they have been using Lemtrada for a long period of time. They have used, what they report is that in the trial data they have used overall, after many, many years, about 50% of patients have used 3 doses of Lemtrada or more. This is mainly driven by the incidence of relapses. So when a patient's disease breaks through and they experience a relapse, despite having been treated with Lemtrada, then they receive additional doses of Lemtrada. Another possibility is that they receive a redosing of Lemtrada after 5 years of have elapsed, and they are due for another retreatment. So what the cohort that we had in our analysis, with 10 to 15% of patients having received 3 doses, doesn't mean necessarily that they were underdosed. They were treated according to protocol, which is 2 doses administered in a 5 and 3 day cycle, 1 year apart. But they didn't require 85% of those patients didn't require additional doses based on the lack of relapses that they experienced during the 5-year follow-up.
Okay. Does that answer that question?
It was my question. If I could just take 2 minutes of your time.
Yeah, sure.
I've read different reports because the actual presentation wasn't recorded or and so on. It's really different reports that I've read about that particular study, and they've been misleading. I mean, they've reported everything under the sun. 1 second, Tisabri is the best. Next one is Gilenya is the best, and so on.
Yes.
What was actually reported?
So yes, I agree. I read those reports myself as well, and not all of them are actually clearly reporting what we said. One of the reasons is that we didn't consent to have the talk presented on the website, and the reason for withdrawing that consent is that this work is currently under review by a journal. But once it's been accepted for publication, we'll be more than happy to release the video on the Extremes website, as well as the paper will be publicly available. So you will have the opportunity to read in detail what we actually did. So the way we reported the results, the way I interpreted the results and concluded, is that alemtuzumab was superior relative to interferon beta or RIBIP in terms of suppressing relapse activity, as well as in terms of suppressing or decreasing the probability of experiencing confirmed progression of disability. Compared to fingolimod, it was superior in suppressing relapses, but it wasn't found superior in terms of its effect on the disability outcomes. And for natalizumab, alemtuzumab and natalizumab were highly comparable in terms of the efficacy suppressing relapses, but natalizumab, unlike alemtuzumab, resulted in that very early chance of recovery from previously accumulated disability that typically occurred in the initial year of treatment, which is about 25% of people have experienced this recovery improvement in disability, which we didn't see in alemtuzumab. In alemtuzumab, it was about 10%. And this is in keeping with post-hoc analysis from the original trials, the AFFIRM and the Sentinel trials, where a similar number, about 25% of patients starting natalizumab showed improvement very early after their first initial doses of natalizumab.
Was it sustained?
It was sustained, so we required confirmation of that improvement after 6 months. Of course, that doesn't mean that it is sustained forever. So people can worsen again, but at least 6 months, their disability on 6 months on 2 separate EDSS readings, their disability levels remained improved. And some people remained improved actually multiple times during that visit, not just one improvement, but they would have had 2 or 3 improvement events.
I think that makes sense.
Okay, fantastic. And as a quick plug, obviously reading information that varies in accuracy online is another reason why we should all be looking at MStranslate for their information, right?
Absolutely.
Got to get a plug in while I can. Andrew and Brad, you guys haven't had a chance to ask any questions yet. Do you have anything you'd like to ask Thomas?
I'd love to ask a couple of questions. I might actually ask the question, then I might have to drop out because I've got some very angry kids I have to deal with in the background. So if I can deal with that. But the question is in the construction of those charts. Did you start them by saying I've got a number of people that at this level 6 and work backwards to see how they got from 3 to 6 and on the way back, or did you say start with a certain number of people at each level at 3 and see how many dropped out, so you could measure the attrition rate as you went up to 6, and what happened to the people who actually dropped out at each of those cohorts on the way through? Did they drop out because something bad happened, or did they drop out because of some other reason? Do you know why the total number would have dropped out?
Yeah, this is a very important question, and this is actually one of the flaws that was in the original LRA paper.
And I am sorry, I do have to go, but I'll watch the replay, so I'm sorry about that.
Yeah, sure, no worries. If you are interested in the actual paper that is coming out, you can send your contact to Brett, and he'll pass it on to me. I'll be happy to share the paper with you if you want to have a more thorough read. So to answer the question, we have identified people who had confirmed disability, reached confirmed disability levels, such as EDSS step 3, 4, or 6. So there were 3 separate analyses, each of them having different defined disability level. And we have looked at everyone who reached that level. So that was the only requirement for inclusion, which enabled us to look backwards at the slope of the disability trajectories before that EDSS step and slope of the disability trajectories after that EDSS step, irrespective of whether these people reached the outcome EDSS score of 6 or not. So that means that we had no attrition bias. People who had benign disease and didn't reach EDSS step 6 were not excluded from the analysis.
Okay. Right, hopefully that answers Andrew's question, and I've just realised the difficulty with having more than one person called Andrew in the chat. Other Andrew White and Brad, do you guys have any questions? We've just entered our final 10 minutes of the discussion. So.
I do. Brad, did you want to go first?
Okay. Yeah. G'day, Thomas.
Hi.
Just 2 points. One, I noticed in the video the other day where the graphs were shown, the straight line shown for the different cohorts. The thing that stuck out to me was, does that indicate, in fact, that the DMD therapies are not actually effective? Because shouldn't that line be a curve instead of a straight line?
Can just let me make sure that I understand which graph you're referring to. So referring to the eminent arrays graph, where in the bottom part of the graph, the curves were straight lines increasing at different rates, and the top part of the graph where straight lines increasing at the same rate?
Yeah, there was a couple of graphs. One I think was the original, and the other was the where above that line it split into a few different.
Yes, that's
lines.
right.
Yep.
So which of the two are you referring to?
Well, I suppose either one. Just the fact that they were straight lines. When
Okay, I see. I got you now. So this is why they are lines. This is a necessity from the analytical point of view. It's an oversimplification of what the real situation is. With an individual person, we are of course able to draw a curve. The curve would be, by definition, wouldn't be a line for two reasons. Three reasons. First reason, there is a ceiling effect. So at certain stage, the progression or accumulation of disability would slow down. Two, because EDSS scale is not a linear scale. So that means that people tend to stay at certain EDSS steps for relatively longer period of time, such as EDSS step 6 versus EDSS step 5 or 5.5, where there people spend relatively less amount of time on that particular step. So that would determine rather uneven shapes of such a curve. And third, because there is an effect of medication, and the medication, as you say, we would expect it to modify the progression through the different stages. We would particularly expect it to modify the progression in the earlier stages more efficiently than in the later stages. Now, the last of my statements is something that is not based on evidence. This is just my impression or gut feeling, let's call it. It will be something very interesting to analyze in our data to see if people with earlier disease have better modifiable disease progression than people in the later stages of the disease. So what you see in the graphs instead is an interpolation by least squares algorithm, which by definition really results in a line, and this is the simplest way how to visualize this data in a large cohort of many patients included in this study. Whereas if we try to, you can imagine if we try to plot out every single curve for every single patient, the graph would look rather messy and probably not convey too much information.
Okay.
Right. I'll just I might just give Andrew a chance just to ask one quickly, just because we've got just over 5 minutes. So I want to make sure everyone gets a chance.
Thanks, Brett. And Thomas, thank you. Thomas, one thing that's been occupying my mind recently is there now seem to be two types of medication. One that is really trying to retard the progress that people are experiencing. And now we're starting to see some medications emerge that are hopefully going to see an improvement in disability that people experience. I wonder if you might comment on whether there's likelihood to be, or value as you would perceive it to be, research into not only the effect of the medications relative to one another, but also what might emerge for individuals that supplement that medication regime with exercise or physiotherapy or something of that nature versus those that purely take the medication.
Absolutely, this is a very important. So I think I'll split that question into two parts. The first part, you're alluding to medication that is neuroprotective, regenerative, versus immunomodulatory medication. So immunomodulatory medication is what we routinely use and will use, but the regenerative medication is something that is really exciting concept for ourselves, but also for patients, of course, because this means that if these medications work, they will enable people to regain some of the lost neurological capacity, which would be a fantastic outcome. So that's why there is a lot of money and effort going into this research. So there's, for example, the two antilingo trials organized by Biogen, which are very exciting, interesting studies. However, at the moment, this is early days. The two trials, the first of the trials done in clinically isolated syndrome, so very early in the onset of the disease, showed borderline small positive signal, but we would have expected more. One of the reasons could be because that the treatment was administered at a delay of up to 4 weeks. So maybe we need to go in earlier and administer the drug earlier while there is more myelin to protect. The latter trial in more established disease, relapsing-remitting disease, showed no positive signal, which was presented at extremes and was somewhat disappointing, but because everyone was hopeful that we will be able to offer people something to recover from their previously acquired disability. But the research goes on, and we hope that there are more molecules in the pipeline. So we hope that over the next 5 years, we'll see more drugs like that with better outcomes. The second part of the question, the lifestyle changes, I think that is the critical point. We have very little evidence, or there is some evidence, but we need more evidence to support the role of lifestyle changes in treatment of MS. But this is actually my opening gambit in the discussions in the clinical rooms with patients with multiple sclerosis, that there is one part that we can do from the outside. We can tamper with the immune system and protect the brain from the immune attack. But the most important part of treatment of managing MS is what they can do for their disease, or for their well-being. And that for those are the factors for which we have sort of more solid evidence. There is, for example, smoking, where we know that being non-smoker decreases the probability of accumulation of disability by 25%. So there are other factors, exercise, diet, which we need more information on, but it's definitely something that's, if it is within reasonable limits, is not going to hurt and has a potential to improve the outcomes.
All right, fantastic. Now we are in our final stages, less than a minute to go, I'm being told. So if we do get cut off, I apologise, but I will take this opportunity just to thank Tomas for giving his time up tonight to come and talk with us all and answer some questions. As always, Tomas is very giving of his time and very keen to make sure that this information gets out to the public. And I think it's worth mentioning that Tomas himself was actually the one who approached was interested in communicating these findings through MStranslate. So it's always very pleasing for us to have people coming to us to want to talk to the community rather than us having to go and beg them to do so. So Tomas, thank you very much for that.
Thank you for the opportunity.
And I'm sure that once this video goes up, if you guys do have any more questions that we didn't get a chance to cover during it tonight, if you drop it in the comment section under the video, I'll make sure that I bug Thomas and pass them on to him so that he can respond as we go forward.
Of course.
Fantastic.